modalities. And so, and of course, that's our job right here in this class to make sure that we know what we're doing as far as groups. What I would like to express is it is true with PTSD. The first line of defense has been shown to be most effectively done on an individual basis. Okay, and statistically, it just kind of shows that. But what we're increasingly finding is that individual-based treatment combined with group treatment is showing even more of an effectiveness, because in the individual setting, you learn about and you kind of do these role plays with the therapists and how to deal with different post-traumatic stress responses and stuff like that. But then we're finding that in the group setting, then you get to practice those with people who have experienced similar events in their life. Okay. Now, if we kind of then try to combine the benefits of individual treatment with the benefits of group treatment, we're starting to develop some newer kind of models of group treatment for PTSD. One of those models is seeking safety. Okay. Now, I'm going to bring this up because this is kind of the one we're going to use as an example. Because what seeking safety does is, I should say, is that seeking safety was originally developed in about 2002. It was validated, I believe, 2004, 2008, and then it's been evolving ever since. Okay. But this is kind of the reason I kind of want to go over this treatment is one, it focuses on PTSD, but also co-occurring disorder of substance use. Okay, so we're going to get a flavor of both types of treatment, both for the substance abuse group and those who are experiencing PTSD. And the other part of this is that it really kind of combines all of this, the different types of groups. There's psychoeducational components, there's treatment components, and there's process components within this group. So it's a good example of a treatment modality that kind of combines all the worlds of group work, but also works on the difficulties of things like co-occurring disorders such as trauma and substance use. Okay. So we've already kind of gone through most of this, so there's no reason to kind of put much more emphasis on it, but just the kind of the history and the development of this therapy is, as most of us know, PTSD emerged from reactions of soldiers that came out of combat originally. The first in World War, well, actually, we can go clear back to the Civil War and into World War I and part of World War II, where they called it shell shock. And then after that, in World War II, and then especially in the Vietnam era, we recognize this as a specific disorder, not just a severe response to something that someone went through. And so based on that, in 1980s, PTSD kind of became an official psychiatric disorder, which if you look at the trends, by the 1980s, we've had about a decade with our Vietnam vets returning, and we're seeing a lot of the PTSD issues, but we're also seeing a lot of substance use issues. So, and at the time, it was very difficult to tie those apart. Okay. And so what we ended up with is some models that want to emphasize both, but make sure that they're represented as two unique disorders. Yes, they can be related. Yes, they can come from the same drives and those kinds of things, but recognition that you have PTSD and you have a substance use disorder. Okay. So there was establishment of clear guidelines to combine the types of treatment that usually utilize some type of homework and practicing behavior. and incorporating the cognitive behavioral therapy that we saw in the videos last Tuesdays and Thursday. Okay. Now, okay. And part of this is, though, is even though we want to see them as two separate kind of disorders, we want to understand what their relationship is. Okay, why is it that people with PTSD have such a higher prevalence of substance use disorder compared to the general population, or even compared to other mental disorders or psychological disorders? Yes, sir.
So like what that says is in 1980, what in my own research that, yeah, 1980, so that took a decade, decade plus for that to actually PTSD to be, taken seriously. So what I've seen from then, so you look at from 1980 to when people started thinking it's a problem, and then they really didn't take it seriously until after 1990, the Gulf War, and then more recently the global war on terrorism, and that started in 2000. I think maybe after maybe 2004, 2007, something like that. And that's so my service was from 2007 to 2013, and I was in a rough time. But so those things, there's no treatment for it. It wasn't taken seriously, so there's no kind of magic pill, as it were. So like depression, there's a form of treatment, CBT, or some sort of pharmaceutical drug that you can take, to a mood inhibitor or a mood, it'll emphasize on that stuff. But from what I've seen is that so when it comes to PTSD and people that have it, um, we don't, there's no medication for us to take. So they'll prescribe you so much stuff and see what works. Pretty much a hit and miss. So you'll in a span of a year, you might be prescribed 13 different drugs to see what works. And if it doesn't work, then they'll just go back to the drawing board, keep doing it over and over and over again. But the thing that I've seen is it's mostly like groups talking about it and getting that thing out, because I mean it's still there. It's just it's like having a stillborn memory right there, right in your, it's just what I see is that it's there's not too much research that has been done about it to actually correlate with what you can do mentally, as far as any kind of psychosomatic drugs that you can take to really bring down that level of anxiety and depression and everything that's associated with it. So all the disorders that you see that are associated with PTSD, that's what you're trying to treat. But PTSD is a little bit different because it deals with a wide array of everything combined. I mean, anyway, that's what I see.
Yeah. Yeah, and one thing that we should note, and this is kind of Dr. Peterson criticism of the whole clinical field, is that there are some treatments that we're getting pretty good at, but even antidepressants don't work for everybody with depression. There's when we look at things like schizophrenia, antipsychotic medications only work with 46% of people with schizophrenia. When we look at other treatment things, we thought lithium was the golden bullet for bipolar, but we're showing that it's not. And so I just want to emphasize the idea is that there's a lot of areas that we don't have a good, solid understanding of, even things like depression. I mean, somebody within a span of 6 months might go through 6 or 7 antidepressants before they find one that kind of works. And so on PTSD, the disadvantage it has, and kind of getting to your point, is that it's kind of, there's two things that are kind of putting shadows over it. Okay. One is cultural, social, cultural issues around the idea that military personnel should not come back with trauma because they were trained for that and they were protecting their country. And a person who is severely abused, once they're away from the abuser, they should just be fine and everything will be okay. And so there's the cultural issues that surround PTSD, which is something that really needs to be overcome because it's a serious issue. The other issue is that it's recognition. Remember, when we look at this disorder, it was barely recognized as a disorder in 1980, right? Um, and again, I'm going back to this history with schizophrenia because it's an example. And even with depression, we had been studying schizophrenia and depression since the 17th century. And you'd think by now we'd have the treatment down, kind of like we kind of do with things like diabetes and those kinds of things. But that's part of the issue that we have is it's also in its infancy. With that being said, those are not excuses. Okay, it's more of just that academic understanding of the state of the science of clinical and whatnot. But what we do need to recognize, I'm hoping this gets to your point, is that we're seeing PTSD becoming a more and more common response to trauma because trauma is so much different than it has been traditionally. Okay. And again, I'll go back to the battlefield notion. Okay. Um, when we look back in warfare, the willingness of a soldier, I'll use that term in a very general way, to want to harm their adversary has increased. Meaning, and okay, so let's start with the Civil War, just as an example. As everyone probably knows, that there was a lot of carnage in the Civil War, a lot of death, but very little of it was due to soldier combat. It was due to cannons. It was due to artilleries. Okay. In fact, when we go back to these places, for every one shot a Confederate or Union soldier made, they wasted 22, meaning that they would fumble it, they'd get rid of it, they'd say their gun was jammed, and they would often miss their target on purpose. Okay. We get to World War I and we see the same thing. This willingness to want to harm another person on that individual level wasn't there yet. World War II, we get a little bit closer, but we have these tools that make destruction much more easy. Then we get into Vietnam, where it is completely encouraged to be aggressive and torture and harm other people. Okay. Now, I'm not saying that you could probably speak to your military training and say, well, they were taught to, take the enemy out, those kinds of things. One could argue that we have a much more understanding military. I don't know. You'd be the expert on that. But this idea that we are witnessing more and more violence because of the tools and the destructive forces we have is increasing. Okay. And the acceptance that people are going to die has become more and more accepted in combat and war situations. Okay. So on the battlefield, it shouldn't surprise us that we have individuals who are so harmed psychologically by what they observed or what they witnessed. Okay. And that is resulting in increased suicide rates, increased substance use, all those co-occurring things. But the primary issue is the PTSD. If we can do something with PTSD, all the research we've had so far shows that all of the other co-occurring disorders can almost resolve on their own most of the time. When we talk about non-combat, I think we have a thing on here. Non-combat treatments, we're finding that the issue that is becoming more and more traumatic, as you would say, is the fact that there's no longer these support systems that are there to help a person. There's the sense of community, the sense of family, the sense of those things have gone way down.
So, to add to that, so when I returned from Afghanistan and I, got done with my deployment, and that was like, 2013. So here's the thing is that when I got home and then I wanted to leave the military and go home, I was, at that point, I was just like done. So, I mean, it's hard to tell an airborne ranger, that just to not, turn it off.
Mm-hmm.
But when I got home, I was home for 3 hours, and literally 3 hours. And what I found was I lost my job, I lost my friends, and I lost my sense of purpose.
Mm-hmm.
So I went right back to work. I went back to ranching, went back to something that to keep my mind off of. That was my own self medication. A lot of people that come back, they don't have that. They
Mm-hmm.
don't, and then to get a job, I mean, I found myself within the first hour trying to look for jobs and see what I could do. And I was sitting in my mom's kitchen looking for jobs, and that lasted about 45 minutes,
Mm-hmm.
and to the point where it's like, you have a purpose, you know what you gotta
Mm-hmm.
do. And that's the basic of it is you're trained so much to do a job, to lay your life down. And like what you said is that you're able to have that mentality of, if I gotta give my life for my country and for my people, I will do that.
Mm-hmm.
But people before that in a different time used to say, I want to live. We're doing it because we want to live.
Mm-hmm.
Now it's, I'll give my life for it. But then when you get home and I see people that have had, there was like a statistic that came out that was like, there's a lot of people out there that commit suicide based off of the fact that, like, why am I still here? That guilt, that I don't know what you call it, that guilt.
Survivor guilt.
Yeah, survivor guilt, exactly. So like they're like, well, why am I here? My friends died, and all this and that. And so then they ended up, taking the alternative, and that's what I have seen. I mean, I have friends that have taken their lives based on the inability to cope with the post-traumatic stress, and that
Mm-hmm.
only happens probably several years after. I mean, after the fact, like
Mm-hmm.
they sit there and they finally realize, like, where's my friends? Where's my purpose?
Mm-hmm.
I'm still struggling to get a job to put, money on the table, and failed relationships, failed marriages, and all this stuff.
Mm-hmm.
It just piles on, and then that's when it comes out of nowhere, and then it hits you to the point where you shut down. So I mean, that's just what I've seen.
No, that's a good example. And it really kind of goes back to, and just to kind of emphasize this point of why uh, group treatments are a good, if you want to put it this way, surrogate for regaining some sense of identity and normalcy, because of the support system that it puts in place, which is the important part. Is there was an interesting research that was done. I don't know how this researcher got military family to agree to this, but what a researcher did is they recorded the phone calls between a deployed military personnel and their intimate partner. Um, and then when they came back, they measured rates of PTSD, depression, all of those things. And it was an interesting thing is that what the researcher found is if the home person, the spouse at home, kept the military personnel in a co-decision making position in the family. So, for example, maybe said, little Joey got in trouble at school today, and this is what the teacher said. How do you think we should respond? That kind of conversation. Not that this is what I'm going to do, and if you disagree with it, that's your problem. And they found that in that relation where the home spouse gave the deployed military person a sense of purpose back home, that they're going to come back and they already have a role and they're there, versus those who just told them what was going on. Sometimes even got angry if the military personnel made recommendations, those kinds of things. And if we just put it in those two simple categories, the individuals who came back in the non-supportive communication role, where they weren't integrated into the family system, had a very high rate of PTSD. However, the group that had that, they were still part of the family, part of that support system, their PTS rates were lower than base rate, meaning what you would expect in the general population. Okay. And going back again to this group idea and this providing a place where people can be with people who have experienced the same thing, they're all going through it and they're all experiencing it. I think this is where you'll see a lot of treatment goes. But anyways, let's on tangents. Good conversation, but let's get through a little bit more about this seeking safety, and we'll see. You'll see some of these elements that you've been talking about, and we've been talking about with PTSD. I think you'll see them, anyways, and then we got to figure out how to make it work. So this treatment comprises of a psychotherapeutic treatment approach, and it can be used for groups and individuals. Okay. There's basically 25 topics that address things like recovery and coping skills. And each of these can be divided into cognitive, behavioral, and interpersonal domains. Okay. So they just don't focus on your thoughts and how you feel about stuff, but they also focus on relationships that you have with other people and behaviors you choose to exhibit. Each topic, and this is an important aspect of this treatment, hence the term seeking safety, includes a safety-oriented skill relevant to PTSD and substance abuse. Okay. Safety being, how do we go about alleviating a symptom, dealing with a relapse in a safe way without creating even more harm or hurt. Okay. Each topic is independent of each other, meaning that they're not meant to be completely integral with each other, but they're just a piece of a huge puzzle, as you would say. Okay, and so these are some of the treatment topics, and again, I'll post this on Canvas soon. And so if you'd like to take a closer look at them, as you can see, the first topic is safety. And it talks very bluntly about how we need to make sure we have healthy boundaries, how we should deal with when we have triggers as we're going through this treatment process. Okay. And then it talks about some of the common experiences with PTSD, about taking back your power, detaching from emotional pain, asking for help, taking good care of yourself. Red and green flags. If you remember at the beginning of the semester, we talked about those, what were they called? Thinking errors, defense mechanisms. This is very much similar to those topics, and you'll actually find a lot of these and when to recognize them to put in a safety plan. Okay. Honesty, commitment, healing from anger, and all of these are just part of the process of healing, according to this model. All right. And based on the model, it goes through 3 stages. And if you want to think about these 3 stages, are kind of way of thinking about a grief process in a way. Okay. Um, uh, so for example, we go through safety, mourning, and then reconnection. So the safety stage is the initial process. It's about learning about the disorder and about substance use and about the red flags and green flags and different coping skills that can be used for each of them. And then in the mourning and reconnection stage of recovery are initiated when therapy work separates from the seeking safety skills group. And what that means is mourning and reconnection doesn't mean the end of the treatment. What it means is that the individual is independently implementing these skills on their own, and they're using them to retake back, as the treatment suggests, but take back their self and their sense of who they are. Okay. I want to make sure we get to, okay. So there are some, based on those, there's some principles, and then there's some things that are sometimes in treatment modalities for PTSD and substance use, but they've been purposely taken out of this one. So let's go over the 5 kind of central principles. Okay. The first one for this one is, as again, as you could probably guess from the term of the treatment, is safety is an ongoing priority in treatment. Okay. And it integrates the idea that PTSD and substance abuse for people who have co-occurring issues need to be treated at the same time. Okay. Because even though PTSD may be driving the substance use, if substance use is being used as a form of self-medication, then that needs to be addressed, as an example. Focus on restoring ideals that have been lost. For content areas include the way people think about it. So those are being able to identify your red flag thoughts versus your green flag thoughts. Interpersonal relationships, how you're building relationships with other people. And the other one is, and this is kind of goes beyond just the group session, is the importance of having some type of case management. Okay, so this specifically talks to those individuals in the class who want to become social workers and really help individuals through the treatment modality. Okay, and the purpose behind case management is you'll establish goals in the group, and then you can work individually with your case manager to then implement some of the things that are difficult. Okay, so for example, working with individuals who had been severely sexually abused very commonly also came from an impoverished area where the person is going to end up homeless or something like that if they go back to, or if they try to leave the abusive situation. Okay. But a goal of safety would be to get the person out of that situation, right? Would be what's most beneficial for that individual is to get them out. So while they're working on the while in the treatment, they're working on the thought processes, the behavioral processes. The case manager can be working with, well, let's get you the resources you need. If it's access, food stamps, anything like those, and assistance programs, so that the goals aren't inhibited by the life situation of the individual. And that's kind of the goal behind that idea. Attention to therapist processes, and this is an important part of this treatment, is it is therapist client centered, meaning that the therapist has an important role in assisting with recovery. And so it includes building alliance, having compassion, or I would use the word empathy, for patients experiencing, giving patients control, like we've talked about, modeling what it means to try hard by meeting patients more than halfway, and getting feedback about the genuine reactions in the treatment. So this is very much in this modality, it's about that relationship. And I'm going to put as much work into this as you are. And I'm going to be here every week, and we're going to go over these topics, and you show up, I show up. Okay. Now, what are some parts that aren't part of this type of treatment? Okay. Well, let's talk first about additional features. Focus on potential rather than pathology. And what that means is that this treatment focuses on the here and now. Okay. If you notice down here, what it's not does is it doesn't do that past trauma or trauma memories. It does. So in this treatment modality, unlike a few other ones, you're not going to be writing a letter to your trauma or something like that. Okay. Because what it suggests, what this treatment modality suggests, is if we alleviate or we heal the symptoms now, it's going to help heal the trauma memories in the past. And that's pretty connected to what we know about memory and cognitive processes. Okay. Our past is not what actually happened in the past, it's how we're interpreting the past today. Okay. And it's always interesting. Just a side note, and sorry for the in that, if we ask someone their favorite birthday, and by now we have recordings of them, so, and then we ask them, hey, bring that recording of your favorite birthday that you had to the lab. Okay. And when they get to the lab, we do an induction thing. So either we do something that's going to put them in a negative or bad mood, or we give them something that puts them in a positive or motivated mood. Okay. And then we record them telling us about that birthday. But then we compare what they just told us to the recording of the birthday. Okay. And what we find is that if we induce someone into a better mood, they tend to remember people who had positive impacts in their life being at their birthday, even if they weren't. And if we put them in a negative mood, they will identify people who brought them down, who wasn't a positive influence, even though in the recordings, that person was never there. Okay. We find the same thing with, for example, memories of 9/11. And we ask, so what were you doing the morning of 9/11? And some people say, well, I was sitting down and I was getting ready to watch the World Series. It was game so and so. And the point of the story is, one, the World Series isn't being played at the time 9/11 happened. Okay. Different days of the week, different time period, different time during the day. You wouldn't see the World Series when the Twin Towers were being ran into. Okay. But what is interesting about those memories is that in those cases where individuals recalled something like the World Series, it's because their team lost that year. So they were associating memories from other negative memories and putting them into this place. Okay. But again, if you change the context, those memories tended to tie out and separate from each other. Okay. Anyways, I bring this up because there's a lot of debate about, should we go back and explore the trauma that happened, or should we focus on how we can work today with what's happening today, and then those memories of the past are going to be reconstructed anyways. So there really is no, so there's a group of people in the group treatment for trauma that says, why re-traumatize someone? Focus on the here and now. But there is still a lot of individuals who feel like that exposure is healing of itself. This treatment modality is one that says we should focus on the here and now. Okay. I'm not going to say the debate is up. There's some that advocate to either way, and you can find evidence for each. But that's kind of the current state, kind of what you were mentioning in here. We don't have a solid, this is the answer. So, but anyways, the other thing that this doesn't implement is things of psychodynamic work, such as exploring interest, psychic motives, and dynamics, the Freudian kind of unconscious drives, and taking a child clear back to their childhood, even before the trauma, and figuring out how they could have ended up connecting trauma in childhood with trauma that occurred on the battlefield, for example, and then PTSD. This doesn't go into that kind of dynamic. I'm gonna kind of get through that. Okay, safety principle elements. So, as I mentioned, one of the first elements, principles of this treatment is safety. Okay, so in safety with substance use, we want to discontinue use, right? Discontinuing use ties to recovery traditions and compatible with harm reduction models. Okay. We want to reduce the suicidal risk. So, what can we put in place to identify triggers towards suicidal ideation, those types of things, and minimize risks? So, self care regarding things like medical, emotional, behavioral needs, and creating more proactive behaviors instead of retroactive behaviors. Okay. Continuing on with this principle, letting go of dangerous relationships. So addressing things like domestic violence, using friends, significant others, gain control over extreme symptoms, coping with things like disassociation, flashback, and related process. I think this one is probably the one that takes about the longest of the safety processes. And then stopping self-harm, reducing cutting and other forms of self-injury. Okay.
I just
Yeah,
wanted to point
yeah.
out with your with your disassociation, um, like, because I mean, as a kid, I was abused too, and in order to cope with some of that stuff, like I would shut myself down, but then also I knew that I had to, just tough it out, as it were. But I was wondering if is there a if anybody was any studying like dissociation disorder compared with people that have been in a combat situation or in those kind of different situations like that, where there's in order to cope with those kind of stressors in that stressful environment, do they actually form a type of personality to where they're able to kind of take that on, and then when they're out of that, then they revert back to who, like just calm, cool, collected, whatever, and I just had a question about that.
Yeah. Well, so one important thing to state really quick before we get too deep into this is that we all disassociate.
Yeah.
We do it all the time. Okay. For example, I grew up in poverty. I'm first generational high school, college, and I'm the only person in my family history who has a doctorate degree. Okay. And so when I go back home up to Idaho and Montana, I'm no longer Dr. Peterson in my head. I have to become the little brother because I'm the youngest of my brothers, and very meek and moderate about my opinions. And I go immediately into that little brother, almost helpless type of mode. Okay. Why? Because that's a congruent association with that environment. Okay. Um, and we can always think of other types of disassociations that we have, like but going back to your example. Okay, so in the 70s and 80s, there was this notion of this idea of multi-personality disorder. Okay, which we don't call it multi-personality disorder anymore. It's actually what we call now dissociative disorder. Okay. And what it is when a person can no longer cope with trauma that they're experiencing, a coping mechanism is to create a persona of someone else that can handle that while we retreat back into our mind. Okay. And that's why it's called dissociative, because what you didn't do was create a personality. You don't have a new unique personality that is existing within you. You have a coping mechanism of what you think would be a better response to that situation, and you disassociate from it. Okay. And very much yet, so the notion, people who have experienced trauma in childhood and haven't got a lot of help for it and those kinds of things, do they tend to disassociate more when traumatic events occur later in life? The answer is yes. um, and it is almost like, if you've ever known someone who has a severe dissociative disorder, it does look like there's two or maybe five different people that exist within the individual, and it's sometimes it's kind of actually nerve-wracking to watch the transformation. But that's severe disassociation. But the thing that I would encourage you all to think about is we're all on a continuum here. I would consider my disassociation when I go visit family mild, not something I'm going to go get treatment for. Uh, but when I have to recess in my mind and I personally forget anything else my persona did, that's where we need to start looking at potential treatments. Okay. I remember, just on this topic real quick, and if you've taken my Psych 101 class, I think I talk about this. The most severe case of disassociation that I ever worked with was a man in Utah who disappeared. And I mean, they did a search for him, couldn't find him anywhere. And he reappeared in New York City. Okay. Now, when he was in Utah, he was married, he had four kids, uh, living parents, all of those kinds of things. He was a college graduate. When he appeared in New York City, he had a whole new family, including new parents. Now, those parents were in a graveyard, albeit, but he had a new occupation. And when we ran memory tests on him, he had no memory recollection of Utah. Okay. And so, what would create that was the biggest question. And what it really came down to is they found out he did some not so good things at his workplace. He was on the verge of getting fired. He had people who hated him extremely in his workplace because of what he did. And then you combine this with parents who were very, very not kind to a child. He created this dissociative figure to escape from his actual existence. And that's the most extreme type of disassociation, is when a person creates an entirely new person. And they absolutely have no memory of their actual past. But I don't know if I just went off on a tangent or if I answered your question.
Well, see, that's the thing is that with that case, one could argue is that was the original person his dissociative person, and then his other personality that came out that could have been the real him. But then if he's escaping that, he's leaving that personality behind, and that could have been the one that was dealing with all of that trauma, all that stuff. And then so then when he finally, the individual finally came out, one could argue that, right? I mean,
Yeah, the only difficult part about that is the real him then created parents.
yeah,
He created, a new job and career, and this is what makes his case kind of question, how do you uh, untwine those, is he could actually take you to his new parents' graves and explain their life to you and what it was like being raised by them. And so that's where I think they probably lean on his specific case more towards that. That's the dissociative figure because he completely erased his real parents and created new parents. So that's where the argument would be. He was probably in the dissociative phase in New York, but it's an interesting debate. These cases are so rare, though, it's really hard to count them out. If you want to ever watch kind of an interesting show, I think it's called Split.
Oh,
Yeah, yeah. Now it's more of a fantasizing of this kind of idea or dramatizing, but it's kind of an interesting. The lady who's doing treatment, she actually probably is a really good therapist. Anyways, so going back to this, let's see. Only between.
that is a good one.
I think they did Split, and then they did a second follow-up one with I can't remember. Anyways, maybe we'll watch that on Tuesday. All right. Recovery attacks, which are common for both PTSD and substance abuse. So this is where in this treatment modality, they're connecting two common approaches to that are both associated with PTSD and substance abuse. So, for example, education, understanding, the what substance can do to you, what PTSD symptoms can do, and how they can affect your life. All of those things. Focusing on present time orientation, and this comes back to the main treatment goals of this type of treatment is focusing on how you're doing right here in your life now. Okay. Assessing the impacts of different conditions. So, if you do relapse prevention and you have someone who does a relapse, you have conversations about the impact. What impact did that have on you? Okay. And that's just an example. Dealing with urges and cravings. Okay. Now, here's a good question for all of you is you have PTSD. What do you think their triggers or urges and cravings are? What do we mean when we say urges and cravings for PTSD?
Would it be like somebody that's in a domestic violence and that person because of how that person was treated, she needed to go back. She feels like she needs to go back into that environment, but that's just one of her negative triggers and she doesn't realize that. Would that be one, like something like that?
Lucinda, that is actually an excellent example. Okay. And I'll bring up a few different types of situations. What Lucinda just explained is an example of urging and cravings when it comes to domestic violence, that you get this urge to need to go back. Okay. I remember working with women in the crisis shelter I managed. And about 3 or 4 weeks into being in the shelter, they would start having fantasy memories of their abuser, and that's kind of the urging and craving process. When we see individuals who, for example, who are severely sexually assaulted, okay, there's kind of two tracks that we trend to see. We see that either they become hyposexual, meaning that they want nothing to do with it. They're disgusted by it, or they become very hypersexual, where they actually can't get enough, if you want to put it in those terms. They become very promiscuous, okay? Those are both examples of urges and cravings when it comes to things like severe sexual assault, is the person can become either really hyposexual or hypersexual, Okay. What do you think for a combat? What would be an example for combat PTSD?
So, one thing would be, you need those dopamine, you know what I mean? Like you need that adrenaline, you need that to feel on the edge of, you know, life and death. So I mean, I went skydiving, I've been bungee jumping, I mean, I used to fight fire, I used to do a lot of things, and I was a logger. So I based everything that I've done to be as you know, the term is an adrenaline junkie, because your dopamines are set so high to that high standard that when you crave that, you need that. So when you pull yourself away from that, and you need that urge to feel just that rush, you know,
Mhm.
like I need that rush, I need that rush. So then that'd be the craving, you know, you're craving, like, you know,
Mhm.
everything's so boring, my job is so boring, you know, say stuff like that. But then your craving would be, man, I need to do something reckless. So then that's where the reckless behavior comes in, you know, and then your urge is to want to go do something, want to jump out of a plane, you know, and I jumped out of a plane for years. So I mean, of course I went skydiving, you know, so
Uh-huh.
I fulfilled that, creating that urge. But I mean, it also goes back to that reckless, you know, people doing reckless things and then coping with it with, you know, what do they call it, self-medication.
Mhm. Mhm.
Yeah.
Yes, Anita. Yeah, strong desire for substances. Yep. Excellent. Excellent examples. Yes. All right. So then the next areas is focusing, of course, on self-care, um, which we'll get to in a little while, and then attention to relapse prevention. Okay, this idea that it's not if you relapse, it's when you relapse. And how can you stop that relapse while it's occurring? Okay. And so that's kind of the focus that it works on, at least in the initial phases. Okay. So some of the things that the goals that we set during this phase is to develop commitment and practicing safety, mastering these coping skills. So this is once first identifying symptoms and then putting in something. Role playing is a huge part of this treatment modality. Utilizing safety plans, report unsafe behaviors by asking for help, and utilizing a safety contract when you have a really strong response to or a really strong urge to use, excuse me, and so it uses, if you want to think about it with the safety part, one, it's asking for commitment, and then it's asking for implementation, but it's also asking you to reach out to those people that you can do a safety contract with, those who can be involved in a safety plan of some type, and people you can trust when you feel like you're having these unsafe behaviors and what to do with those.
One thing to add to that would be, before you have that in, you know, start planning, actually have a good support network
Mm-hmm.
established before you start, you know, with the planning. So then you incorporate those people as well, like, you know,
Mm-hmm.
whether it be a therapist or your close friend or someone that, you know, that you
Mm-hmm.
trust. So then, you know, your whole safety network that, you know, your
Mm-hmm.
supportive network that you have, be incorporated to that as well,
Excellent.
because
Mm-hmm.
they're the, you know, they're gonna be the first people that you call, you know, whether
Mm-hmm.
it's like having a sponsor too, you know, like
Mm-hmm.
stuff like that.
Yep. Excellent. All right. Now this is where we need to talk about you guys. So we're getting into, we've kind of skipped a few principles. Most of them dealt with safety and stuff. But principle 5 is really the crux of what we're talking about in this class. And this is the attention to your processes as the therapist, the facilitator. Research indicates, and this shouldn't be surprise, that patients with substance abuse in particular, that the effectiveness of treatment is determined as much or if not more by the therapist as a therapeutic orientation or patient characteristic. This means just basically, this means that when there's a strong uh, patient therapist connection, the more effective that treatment is going to be. Even if it's given the same way by different people, if that connection is not there, it's not as an effective treatment. Okay. And that's why we've been focusing on all of these things throughout this semester. So it emphasizes building very positive therapist processes, such as building alliance. Again, I'm going to use the word empathy instead of compassion. And the what this treatment modality asks is that the therapist work just as hard as their client. Okay, that they're there just as committed and into the treatment as the patient is. Okay. And this is, again, done through all of these things that we've talked about this semester. Okay. And then again, solicit that genuine feedback from patients about the treatment they're experiencing. So that's that whole patient-oriented Maslowian idea. Okay. Yes. Other parts is that we want to have attention to problematic countertransference reactions. Okay. Again, when we look at what is countertransference, it's when you're hearing things from your clients and then you then transfer your own emotional, psychological reactions onto your patient. So you're no longer in the helping process. You are in your own triggering response process. Okay. And these often happen in these types of situations. So harsh confrontations, when talking about a very difficult situation. Okay. Can create this notion of countertransference. And if you think about it, if you've ever been on for example, an argument on Facebook or something like that, you always start talking about the topic, right? But then all of a sudden you both are giving personal attacks to each other, right? So that person may not even know you. It might be the first time they've interacted with you, but all of a sudden you're the biggest a-hole in the world and you must be dumb as rocks for the way you're thinking, right? Don't know you, but this is what this is. This harsh confrontations led to what's called countertransference. They started to transfer their own emotional state onto you and give you those characteristics. Okay. This is something that I know we've talked about in this class, is avoiding voyeurism. So making sure that when you ask a client a question, you're not fulfilling your own emotional need to know something about something that happened. And this is I'll just to be very clear, this is very difficult and when you're working with people who have gone through trauma. Okay. Because everyone wants to know what happens on the battlefield, right? What happens out there? Everyone wants to know, what what the sexual assault victim did to put them in that situation, or talking to domestic violence survivors about, wow, so what kept you there? What was it about him or her, and why, and those kind of things. None of those questions have any therapeutic value. None of them are going to help your patient heal, but you're satisfying your own need to know, your own emotional state. Inability to hold patients accountable, such as misguided sympathy rather than encouraging accountability and growth. I'll just do a few of these. Allowing patients to scapegoat the group treatment and becoming the victim in the treatment process. Okay. Now I'm going to combine these three because I have an example of a young lady that I did work with in the prison system who went in there. She was doing relapse prevention work with inmates and everything else. But I will tell you, the end situation is she ended up being an inmate with the people she was treating. Why? Because some clients recognize countertransference. They recognize they got you emotionally and psychologically and socially, and they capture that. And so, what a lot of the inmates did is this particular provider had a hard time holding her clients accountable, because she's had so much empathy for them and what they've been through and everything they've gone through. And she would let them scapegoat and talk about. Sometimes I would sit through one of her treatment things and they wouldn't even talk about anything dealing with treatment. And they made her become the victim and saying, your life must be so horrible. Now, in that situation, this is where it can become manipulative from the client to the patient, where they then befriended her, and then they got her taking letters to people on the outside and bringing them in contraband. And I'm not going to get into the rest of it, but it did end up where that person ended up committing so many criminal behaviors on behalf of these individuals who she thought she was helping. She ended up being in that same place. So this is where you have to be very careful. The other area that you'll need, I would encourage you to be careful in, we haven't really talked about ethics a lot, but even the most well-intending, well, I'm not going to say, I am sure that there are people who go in this field with either a conscious or unconscious want to take advantage of other people. This happens in any field, okay? But I'm willing to bet that the majority of people in this class and wanting to get into this field aren't doing it because they want to, they do it because you want to help. You want to help people heal. You're not going in it to take advantage of other people. I'm assuming and I'm hoping not, okay? But going But can the most well-intending therapist end up doing very unethical behavior? And yes, they can, okay? Because of countertransference, okay? Working with social workers and therapists as both a clinical and administrative supervisor, I always saw this come out when a therapist or social worker had been working with a client. They'd been making a lot of progress, and they were actually getting very close, meaning that the client starts to bring the therapist gifts, those kinds of things, not intending anything, just being grateful. Okay. And then usually what would happen is a very negative event in the therapist's life. Maybe they got in a huge argument with their spouse, or maybe this happens because we're not paid that much. Their car gets repossessed, or they lose their house, or something like that. And that major event led to a need to almost disassociate, we could use that term, get away from, have something that is just theirs. And this is where most sexual relationships occurred between therapists and clients in my supervisory history. It always had that formula to it, always. And some of these therapists were some of the most empathetic people you'd know. You would never expect them to do something like this. But this is why, again, we have to go back to what we call emotional intelligence, remember? And remember that we need to keep our own emotional states in check. And we need to be able to read the room and the emotions in the room as those are those person's emotions, My job is to manage them, not to own them. Okay. And so I would encourage you to look out for this issue of countertransference, because even if you, even in some cases, countertransference is a good thing to experience because it allows you to understand the emotional reactions of people. But if you don't make sure that those two things are separated, and then something significant happens in your life, that can lead you down an unethical road. And again, your patients, if they start to see this develop and they have a history of manipulation, then can start manipulating you. Okay. So kind of keep these things in mind as the therapist. Okay. Okay. I think we hit both of those. You know what? I think we will end here. I'm going to stop recording because this is our next